Good afternoon, Libya, and everybody, doctors, and thanks for being with us. And we'll introduce, as Stefan was telling, a new concept in the treatment of vitiligo. The name is VitilC. You know, of course, about vitiligo. It's a chronic acquired disease of pigmentation, and the characteristic is the destruction of melanocytes, and the consequence, of course, are white macles, depigmented macles. And this is an old disease, you know, because the term vitiligo by itself is deriving from Latin language, and Celsus was the first one to use it 20 centuries ago. So there was already vitiligo, but it was really correctly described in medicine, in dermatology, in the course of the 19th century. Vitiligo is the most frequent disorder of pigmentation. About 1% of the global population is affected. I think that maybe in Libya more than 1%. That's what I heard. You know that you are quite strongly affected with vitiligo. Both genders are equally suffering it, males and females. And this is, let's tell, a young disease, or disease for young people, as 70 to 80% of cases are occurring before the age of 30 years, and almost 40% before the age of 12 years. And on the contrary, it's quite infrequent, you know, that vitiligo affects elder people. And of course, elder people who had vitiligo in their youth will stay with vitiligo, but new occurrence in elder people is very rare. It's not a severe disease, you know, because you cannot die with vitiligo. You cannot have complications. It's not painful. It's not itchy. It's a very silent disease, but you cannot tell it's not a severe disease, and especially to the patients, because vitiligo is affecting their well-being, their self-esteem, and really these patients with vitiligo have very serious problems, you know, about social isolation, depression, sexual relationships, and even about marriage. You know, in some countries like India, it's very difficult for vitiligo patients to get married. About classifications, we have two main forms, segmental and non-segmental vitiligo. The second one is divided in three major subsets: generalized vitiligo, acrofacial vitiligo, and universal vitiligo. Here we have segmental vitiligo. Usually segmental vitiligo is only one lesion, you know, no more than one lesion. And non-segmental, many more lesions. It may be also one lesion, but usually there are numbers of lesions. Acrofacial is affecting only the face and extremities, you know, hands and feet. And about hands and feet, we'll get back to this, but they are very difficult locations to be treated. Generalized vitiligo will affect any part of the body, and universal vitiligo is named when the disease is affecting more than 80% of the skin surface. This is a complex genetic disease, and you know very well about this. You know that we have families with vitiligo, and up to 20% of vitiligo patients are showing at least 1 first-degree relative with vitiligo. It's a big number. And the relative risk of developing vitiligo in first-degree siblings has been found to be tenfold higher than in general population. Can you imagine? Really, when there is a person in the family with vitiligo, there is a much higher risk for other members of family to have it. And 50 genes at least have been evaluated, and have a link with vitiligo, but probably many more. Which is etiopathogenesis of vitiligo? There is autoimmune theory. And why? Because vitiligo may be associated with several autoimmune diseases like thyroid diseases, alopecia areata, Hallon-Levy, Addison's disease, which are clearly autoimmune diseases. And the role of anti-melanocyte antibodies in vitiligo is still not well known, but it was shown that the presence of cytotoxic T cells in vitiligo skin, and these lymphocytes will kill melanocytes. And we know, all of us, we know that there is no more melanocyte in vitiligo lesions. This immune response is driven by TNF-alpha, tumor necrosis factor alpha, the levels of which are increased in biopsies of vitiligo lesions compared to normal skin of the same patient. When there is occurrence of a lesion, TNF-alpha level is higher. And by the same way, patients with a strong TNF-alpha staining were characterized by higher vitiligo activity, and higher the level of TNF-alpha, higher the activity of the disease. And everybody knows that this TNF-alpha, this factor, can inhibit melanogenesis. And this is why melanogenesis can be stopped when the level of tumor necrosis factor alpha is higher. It's also leading to an inhibition of melanocyte proliferation, and TNF-alpha is generating oxidative stress, and we know the importance of oxidative stress, and especially H2O2, hydrogen peroxide high levels in vitiligo skin. And last but not least, inhibitors of TNF-alpha were found to be beneficial for patients with progressive vitiligo. Well, another very important major factor is interferon gamma. And there is also an increased expression of interferon gamma, which is playing a pivotal role in vitiligo-induced depigmentation. Why? Because interferon gamma is inhibiting melanogenesis and may also induce senescence in melanocyte. Well, further to TNF-alpha and interferon gamma, we have several cytokines which are increased in vitiligo skin. Interleukin 1 alpha, which is a pro-inflammatory cytokine, interleukin 6, another pro-inflammatory cytokine, interleukin 10, 17, all of them are pro-inflammatory cytokines and are found to be at higher levels in vitiligo. Well, biochemical theory, we told about oxidative stress, which is considered as one of the possible pathogenic events in melanocyte loss. H2O2, hydrogen peroxide, we told about it, and we know that some treatments are based on antioxidants for this reason. So about treatments, current treatments. Of course, what we are looking for is restoring skin repigmentation. This is the only thing which is important, you know, for the patients. And the first-line therapy are topical corticosteroids. And why? Because they are efficient, they have efficacy, low cost, and availability almost everywhere. The second line would be topical calcineurin inhibitors, namely tacrolimus and pimecrolimus. And if you have to choose between both, tacrolimus appears to be more efficient than pimecrolimus, according to published clinical studies. And about systemic therapy, steroids are the principal therapy. You know, when there is a lack of efficacy with topical therapy, we are prescribing systemic steroids, or also oral methotrexate, which is safe and effective in vitiligo. We have physical therapy. It's very important, you know. We have three main types of physical therapy for vitiligo: narrowband UVB, phototherapy with UVA and surveillance, which was the ancient trend, you know, ancient treatment. And first we had this one, and second narrowband UVB, and more recently monochromatic excimer light laser, you know. And one of the most effective and safest types of therapy for vitiligo is probably narrowband UVB, 311 nanometers, and this is very common. We know very well how to use it and how to get results for the patients. And further, it's a safe therapy. We know we have many years of using it, and we know this is safe. A surgical therapy may be useful in patients when medical therapy or physical therapy have failed. And in this case, there are several surgical techniques. I am not a specialist about it. I will not emphasize about this, but there are several techniques, and it's working, it's doing well, but under the condition of having a good skin surgeon, you know, because it's not easy surgery, and one must be trained about this. So, what to do when we want to design vitiligo therapy, and especially topical vitiligo therapy? We must keep in mind that vitiligo is a multifactorial disease, you know, and this is not only one cause and only one responsible, but a lot of responsible, you know, like in a watch, you know, if you stop at one point, it will stop on the other points. And this is the same in vitiligo, you know. There are a lot of factors which are related, and if there is a failure in the mechanism, we'll have vitiligo, and the patient will suffer white macles. And there is a long listing, you see, of targets in vitiligo therapy. The first one is the melanocyte reservoir, you know, and you know that this melanocyte reservoir is especially in hair follicles. When there is vitiligo, sometimes hair is still colored, you know, pigmented. And why? Because there is a melanocyte reservoir in hair follicle. And also unaffected melanocytes within areas of depigmented epidermis. You know, sometimes also we are seeing big white macule and small dark points. And these are possibilities, you know, of repigmenting. And of course, melanocytes at the edge of the lesions, you know. And we have to target all of this. And UV light is a key factor to induce melanocyte regeneration. You know, we must expose the patients to UV light, and we must not use too much photoprotection with vitiligo patients. And why? Because UV radiation is activating P53 protein, you know, which is inducing expression of alpha melanocyte stimulating hormone, of stem cell factor, which is developing more and more melanocytes, and basic fibroblast growth factor. These are the three major factors, you know, that we must target in order to reactivate the melanocyte reservoir. And we told it, stem cell factor is playing a crucial role in the activation of this melanocyte reservoir by stimulating melanocyte activation, enhancing melanocyte mobility and proliferation. And it's not, you know, for some reason, SCF expression is significantly reduced in vitiligo tissue. And why is there vitiligo? Because the common role of SCF is this one. And if there is a reduction of stem cell factor, we have vitiligo lesions. Third, targeting basic fibroblast growth factor. In a similar manner, this factor constitutes a key factor in the stimulation of melanocyte activation, mobility, and proliferation. You know, they are playing together with stem cell factor and acting together on the melanocyte. And in the same way, there are lower levels of BFGF in vitiligo lesions than in normal skin. Fourth, targeting keratinocytes. And you know, this is a very well-known concept that there is a crosstalk between keratinocytes and melanocytes. And you know that melanocytes without keratinocytes cannot do anything. And this is why we must have strong keratinocytes in order to support and to stimulate melanocytes. And what are they doing? They are providing a complex of paracrine factors and adhesion molecules to melanocytes, and these permits regulating melanocyte survival, proliferation, and differentiation. And we know very well that in absence of keratinocytes, it's very difficult to grow melanocytes in culture, even if we are bringing these factors. There is really a very strong interaction between both of them. Another very important target is WNT beta-catenin pathway, you know, and this is quite a new concept in melanogenesis, in skin pigmentation. This pathway is activating melanocyte stem cells, both in vitro and in vivo. It may also be important for melanoblast specification. You know, this is important. This is a precursor of melanocyte. If we are claiming that we have less melanocyte, we must have more, and so on, we must take care about the precursor, which is melanoblast, and have a specific production of melanoblast. And of course, WNT beta-catenin signaling is regulating transcription of genes like MITF, which have a key role in melanogenesis, and downregulation of WNT signaling results in altered melanocytes morphology and organization. And you know, I will give you a very good example. In the human body, there are two locations where there is no WNT receptor. This is the palm of the hand and the sole of the feet. And all of them, even African people, we have white hand palms and soles of the feet. And why? Because there is no receptor. Then this pathway is very important in skin pigmentation, in melanogenesis. We have also to target transforming growth factor beta, because high levels of TGF-beta1 have been detected in the serums of patients with vitiligo, and the area of lesions of depigmentation is positively correlated with these elevated transforming growth factor beta levels. And we all know that TGF-beta is able to inhibit the proliferation and terminal differentiation of normal melanocytes. As we told it, we must target tumor necrosis factor alpha, interferon gamma, we explained it. We must target pro-inflammatory cytokines. We already talked about this, you know, not only to target inflammation, but also indirectly to target oxidative stress. We can target it directly through nitric oxide, you know, which is leading to autodestruction of melanocytes. We must reduce the levels of nitric oxide. We must target melanocortin-1 receptor, which is one of the key proteins involved in regulation of skin pigmentation and hair pigmentation. And in vitiligo patients, the levels of this receptor are significantly lower, so we have to activate this receptor. We must target cyclic adenosine monophosphate CAMP pathway, and activation of MC1 receptor by alpha melanocyte stimulating hormone is leading to activation of this CAMP pathway. And it's directly related with differentiation of melanocytes and pigment production with melanogenesis. And this is an interesting factor, you know, skin pH and melanosomal pH. And you know, we used to tell, and this is right, that physiological pH of the skin is 5.5, and we must maintain this pH, you know, for healthy skin. But for increasing melanogenesis, it's not the same, you know. Melanin synthesis, melanogenesis is maximal at a pH of 6.8, very close to neutrality. So we have to reach this level in an optimal situation, you know, to have the best melanogenesis possible. And finally, targeting microphthalmia-associated transcription factor, MITF, which is a master regulator of melanocyte development, function, survival, which is regulating melanogenesis, and which is in vitiligo with a significant decrease, you know. And so we have to target it and to try to stimulate MITF levels. And you see, this is a summary. You see that this is a very complete activity of this topical therapy. You know, if we want to be efficient and more efficient than any other therapy, we must try to collect all these effects in the same product. It's not easy. And our product is a combination of two vegetal active ingredients. The first one is this plant, you know, Coleus forscoli, which is from Indian origin, but also when I see it's in Egypt, in Ethiopia, maybe you have it also in Libya, I don't know. And the good thing of Coleus forscoli, it's containing quite a number of active ingredients, but the most important is an alkaloid, and the name is forskolin. And what is forskolin doing? It's increasing the expression of stem cell factor. You know, we remember we have a low level in vitiligo, we must increase it. And forskolin is able to do it. Is able to increase the expression of basic fibroblast growth factor. Is able to increase the number of keratinocytes and stimulate these keratinocytes. Forskolin is able to stimulate and very strongly WNT beta-catenin pathway. Forskolin is also able to reduce the levels of TGF-beta. You remember we have high levels in vitiligo, we have to reduce it. Forskolin is able to do it. Able to reduce the levels of TNF-alpha. Able to reduce the levels of interferon gamma. Forskolin may also decrease the levels of pro-inflammatory cytokines and in indirect way decrease oxidative stress. Forskolin is inhibiting nitric oxide synthase, which is necessary for the production of nitric oxide. It's able to increase the expression of MC1 receptor and stimulates very strongly, we'll see a picture after, CAMP pathway. And in pigmentation, this is very important because forskolin is bypassing the function of MC1 receptor by activating adenylyl cyclase and to tell it more clearly, by increasing CAMP levels. You know, forskolin is a direct stimulator of CAMP. And in vitiligo, melanogenesis is defective by a functional disruption of MC1R. And if we can bypass it, you know, in this case, we'll get pigmentation even with the negative factors of vitiligo. And in this way, pigmentation could be rescued in red blonde-haired mice, you know, by topical application of forskolin without the need for UV light, and this is important. And this demonstrates that the pigmentation machinery, that melanogenesis, is available despite the absence of functional MC1 receptor, because you know MC1 receptor needs UV radiation. And topical application of forskolin to the skin of these mice resulted in accumulation of eumelanin, of dark melanin, in the epidermis. You know, this is not a stain, and this is really melanogenesis and melanin production. And you see the control mice, you know, without application of forskolin, and these mice are the same ones with application of forskolin solution during 21 days, 3 weeks. And you see that there was really melanogenesis and melanin production. And in humans, it's occurring in the same way, you know. And this melanin persists through 3 months of daily application, you know. It's not something which will disappear very quickly. It will last for 3 months. And this application was associated with an increase in the number of melanocytes. I told you that forskolin is able to increase the number of melanocytes. And also, this short-term topical regular application of forskolin is promoting eumelanin induction, and over time, if you continue this topical application, you have persistent melanization, epidermal cell accumulation, and some kind of skin thickening. And why? Because it's, I told you also, it's stimulating keratinocytes. And the second plant in our product is named Cassia Alata. And this is a plant from Mexico, but also you can find it in Africa, in Asia, almost everywhere. It's containing a number of phytochemicals, but one is very important, is rein, which is an anthraquinone moiety. And this is the active ingredient of Cassia Alata. It has antioxidant activity, and this is good for us. You remember that there is oxidative stress in vitiligo, and we need potent antioxidant. It has anti-inflammatory activity. This is most welcome. You know, Coleus forscoli is also an anti-inflammatory, but if we can associate two active ingredients, better. It has immunomodulatory activity because it's able to reduce the expression of not only from inflammatory, pro-inflammatory cytokines, but also interferon gamma, tumor necrosis factor alpha may be reduced in presence of Cassia Alata extract. And this is very important, you know, this extract has been found to be effective in inducing differentiation and migration of mouse melanoblast cell line. You see, it's inducing differentiation of melanoblasts, and we need this, you know, to replace missing melanocytes. It was found to cause 3.5 to 3.8 fold melanin induction in this melanoblast after 4 days. And you see, not only it will induce melanoblast production, but also induce melanin induction by these melanoblasts. It can also stimulate dendritogenesis and pigmentation of melanoblasts in a similar way to alpha melanocyte stimulating hormone. So it's a potent factor of stimulation of melanoblasts. And then the formulation of Vitil-C is a combination of both these active ingredients, Coleus forscoli root extract and Cassia Alata leaves extract, and the cream, the gel, it's a gel, it's not a cream, has a pH of 6.8, which is optimal for stimulating melanogenesis. And as you can see, these were all the targets we had at the beginning. You remember a number of targets to get multifactorial action of the product. And if we combine both active ingredients, we can fulfill all our obligations, you know, and finally the product is responding to all these demands and all these necessities we had previously listed. And now, you know, it's very interesting to listening to how the product is working and some things like this, but we need clinical study about the efficacy and safety of the product. And what the patient is asking for is results, of course. he wants to repigment, you know, and nothing else. And the same for the dermatologist. If he wants to satisfy the patient, he must prescribe a product which is able to quickly, rapidly repigment the patient. And this clinical study, we did it with Professor Torello Lotti in Italy. You know him, you know, he is in Rome University, as I am, and he has a lot of academic distinctions, and he is considered as a major specialist of vitiligo. And he took 40 patients, 23 females and 17 males, age 18 to 49, normal blood examinations, and vitiligo covering 8 to 14% of skin surface. Because you know that when the skin surface affected by vitiligo is too high, there is no way to using topical therapies. This is not very useful. And he excluded patients with vitiligo affecting only hands and feet, because we know that it's almost impossible to repigment it. And this is important. All systemic and local treatments for vitiligo were stopped 10 weeks before our trial. And the treatment was for 15 weeks. 15 weeks is about 4 months, you know. And we had 4 groups of patients. One treated with narrowband UVB focus therapy once per week for 8 weeks, nothing else. Another group treated with narrowband UVB plus Vitil C. One group treated only with Vitil C, and the fourth one was the control group, you know, with placebo. And what did we do? Photo evaluation with and without wood light at D0 and after the end of the treatment at 4 months. These are the results, you know. UVB only, increase in the pigment area 28%. Vitil C only 19%. UVB only is better than Vitil C only. But if you combine both Vitil C and UVB, you have a very good result of 41%, you know, much better than UVB only or Vitil C only. Really, this is the right treatment for the patients, you know, combination of Vitil C and narrowband UVB. And of course, placebo had no effect. And this is a graphic illustration of this result, you know. Vitil C alone is a little lower in terms of results than UVB alone, but combination of both is really very synergical. And very important, you know, because sometimes we have side effects and the patients are not very satisfied and so on. Absolutely no side effect was observed along the study. And conclusions, if the patient is very far from the hospital and so on, there is no UVB, no possibility of narrowband UVB, then Vitil C cream, gel, is susceptible, you know, of inducing repigmentation by itself. There is no really necessity of combination with narrowband UVB. Narrowband UVB is helping, giving better result, but Vitil C alone may work. And what we recommend in places where there are few narrowband UVB equipments or it's difficult to get access to them, is to use sun exposure, you know. And if you recommend your patient using Vitil C once a day in the morning, this is the best time to apply it. And sometime after, maybe at 10 o'clock 11 o'clock in the morning. They expose the lesions to the sun radiation during 10-15 minutes. This is the best way to get result with VTLC. And I try to compare the efficacy, you know, of VTLC alone with UVB alone in terms of the studies in the literature. And we have almost the same activity, you know. If you make an average value of all these results, we have the same activity. And the same about tacrolimus, you know. We can tell that VTLC has an activity similar to that of tacrolimus. Well, clinical cases, and something is important, you know. Remember the mice, you know, when we were applying the solution of forskolin on the mice, we talked about 3 weeks. And you see that in our patients, they are not mice, they are humans, you know, but we get results after 2 weeks. I don't tell you they are perfect results, you know, but they are not bad. If you compare before and after, this is not bad. And this is after 2 weeks. And this child, this boy, is 6 or 7 years old, and he got this first vitiligo lesion, you know, on the neck. And by using VTLC only for 1 month, it was possible to stop it and to repigment the skin. But once more, it was a starting lesion, you know, and this boy was just starting vitiligo. This girl also, she is 15 years old, and we had a very good result in 2 months. And now, result after 4 months, you know, from the study, you see that we have good result, you know, and really, you can see it in the wood lamp, you know, there is a repigmentation, but you can see that there were still some active melanocytes, and what we did was to stimulate them. Here also, we had a very good response. You see that the width and dimensions of the lesion are reduced, and the good thing is also these small spots, you know, because they are islets of repigmentation, and probably we can get complete repigmentation in this patient. Well, this one is also not so a good result as the previous one, but you know very well that on the articulations, on the joints, it's very difficult to get a good result because there are areas, you know, of contact, and this is not good. You know, it's if there is some scratching, it's not a good thing. And this one is also a very good example, you know, of repigmentation from the isolated melanocytes which are remaining. This man also had good result. And on the eyelids, you know that sometimes we can have very, very good results on the eyelids. And in this case, we had it. Even on the feet, but it's not very easy, you know. And I don't want to tell you, but it looks like there is some possibility. It's out of the study, you know, because we didn't take feet lesions and hand lesions in the study. This is another case, separate case. But maybe there is some kind, you see that it looks like improving, but it's very difficult. This patient also, after 4 months, you see that here there is a strong repigmentation, and here also. And this is another kind of repigmentation. You see, it looks like the macule has no active melanocytes, and we must act on the melanocytes on the edge of the lesion, you know, in order to repigment it. So, and this is the product, and we have 40 grams tube, and to be launched very soon, 15 grams. And 15 grams is enough for 1 month for face lesions, you know. So it's more affordable for the patients. And 40, if you have limited lesions of the face, 40 is enough for 2 months, for maybe a little more than 2 months. And as you saw, I think it's important to insist about this. You may have results after 2 weeks. And this is very good because the patients are considering that the product is working and so on. And this is promising for them, you know. And the second thing, if you want really good results and stable results, we talk about 4 months. This is, let's tell, the timing with the product for getting result.
I would like to thank Dr. Mohamed El Nawi for this organization, because he was asking the doctors to come and to join us for the meeting. So thank you very much, Dr. Mohamed El Nawi.
Thank you, doctor, and thank you to everybody. I hope we can make another seminar or another event very soon with you in Libya, before we can go back and visit you again very soon. So thank you very much. Have a nice day. Bye-bye.